hepatology. He's done a great work for this condition of liver, which certainly doesn't come immediately to the minds of people who manage liver disease. It's always hepatitis B and hepatitis C and all that. And after a little thought, people start thinking of other diseases, especially autoimmune liver diseases. And it's a host of diseases. It's not just one or two, but many diseases accumulate to confirm that this person, this patient of ours, has an autoimmune etiology. His CV reflects great work on this subject, and he has contributed to national and international press, by manuscripts on the same subject. I would go on for a while, but in the interest of time, I would only say that Dr. Ma's research interests are mainly focused on autoimmune liver diseases and non-alcoholic fatty liver disease. He has received several grants from the National Natural Science Foundation of China and the National Distinguished Young Scholarship in 2013. Dr. Ma has more than 50 peer-reviewed papers in international journals such as Gut, Hepatology, Nature Communications, and Journal of Autoimmunity. So it's a privilege to introduce Dr. Ma. Dr. Ma, please, we are very keen to hear from you regarding your talk this afternoon. Thank you very much.
Dear Professor Jafri, and thank you for your nice introduction. And Professor Sarin, it's my great honor to introduce the management of autoimmune hepatitis. I will focus on new progress and our experience in Shanghai. So autoimmune hepatitis liver disease include autoimmune hepatitis, primary biliary cholangitis, primary sclerosing cholangitis, and IgG4 related sclerosing cholangitis. So the autoimmune hepatitis is the most distinguished disease among the autoimmune liver disease. It was characterized by the elevated ALT, AST levels and positive autoantibodies such as ANA, SMA, SLA, LKM1. In immunologically, it has elevated IgG levels, and in histology, they have a typical histology in liver. And the most important feature is good response to immune suppressive treatment. The clinical profile of autoimmune hepatitis is quite wide. It can be chronic mild hepatitis, but it can also be acute, even severe disease. The pathogenesis of autoimmune hepatitis is not fully illustrated, but the conception is when people have a genetic predisposition triggered by extrinsic trigger or intrinsic trigger, it can induce pathological self perpetually autoantibody, autoantigen, autoimmunity in liver. So our group focused the study on the gene susceptibility, environmental factors, especially the microbiome and the immune microenvironmental changes in liver. In the genetic aspect, several years ago, a study from Dutch JAVA study found the type 1 autoimmune hepatitis is associated with variants in HLA region and identified variants of SH2B3 and CAD10 as likely risk factors. 3 years ago, we initiate a Chinese AIH-JIVA study. We include more than 1,700 DNA samples of patients with autoimmune hepatitis. We already finished 1,600 DNA chip screen. And the good news is we found several genes with SNP variant outside the HLA region. I hope I have a chance to share the new data next time. And we also did a gut microbiome study in autoimmune hepatitis patients. We included more than 100 patients with a newly diagnosed autoimmune hepatitis, never used a steroid, and compared to health control, we found that autoimmune hepatitis has a decreased alpha diversity and altered overall microbiome composition in patients. And at the genus levels, we found 11 bacteria changed dramatically from the health control, which has 4 genus increased. The most changed is Venerola and Klebsiella genus. And the logistical regression analysis and identified 4 genus, includes Venerola, could distinguish autoimmune hepatitis from controls. And the analysis in the association between gut microbiota and clinical variants, we found that Venerola dista is associated with increasing severity of autoimmune hepatitis. We can see patients with higher LGG level, they also have a higher abundance of Venerola dista. Patients with increased inflammatory degree, they also have a higher level of Venerola dista. So we hope in the near future, gut microbiome signature could be used as a non-invasive biomarker in autoimmune hepatitis. Recently, one study from England showed that from 1997 to 2015, the incidence of autoimmune hepatitis doubled from 1.27 to 2.56 per 100,000 population per year. And we analysis retrospectively of our cohort. Those patients majorly come from Eastern China to our center, but we also have a lot of nationally patients. They have a peak age at the 55. It was younger than West countries, and they also have a small peak around the 20s. So the female to male ratio is 5:1, and it's still female predominancy, and they have a ANA positive ratio about 82%, and SMA and F-actin around 38, which was lower than West country. We have very lower ratio of SLA positive. SLA is quite specific for autoimmune hepatitis but have a lower positive ratio. 2/3 of patients had liver histology data. Recently, AASLD renewed the autoimmune hepatitis guideline. In this diagnosis recommendation, they say autoimmune hepatitis diagnosis requires compatible histology findings and is further supported by the following features, which is elevated serum AST levels, elevated serum IgG levels, and all positive serological marks, ANA, SMA. And we need to exclude the other chronic liver disease. So this figure showed that when you meet a suspected autoimmune hepatitis, we need to check the autoantibodies and do the liver biopsy. If patients have ANA, SMA, and the interface hepatitis or plasma cells infiltration in histology, we can diagnose autoimmune hepatitis. But the antibody negative cannot exclude the autoimmune hepatitis diagnosis. If they have a bile-duct injury or loss, we need to suspect the PBC or PSC. So the liver histology seems be dispensable for diagnosis of autoimmune hepatitis. The feature of autoimmune hepatitis in histology include interface hepatitis, plasma cell infiltration, hepatocyte rosette, and enteropoiesis. So our group study showed that enteropoiesis was observed in 2/3 patients with autoimmune hepatitis. And enteropoiesis was associated with more severe nuclear inflammatory features and more advanced fibrosis. And we identified the major immunocells of enteropoiesis by the confocal staining. We found the major cell is CD8 positive T cells, and the result is the enteropoiesis can induce the apoptosis of hepatocytes. So in 1993, International Autoimmune Hepatitis Group developed the comprehensive score system and revised in 1999. And in 2008, International Autoimmune Hepatitis Group also developed a simplified criteria for the diagnosis of autoimmune hepatitis. We validated this two score system in Chinese patients. They all have good performance when we diagnose autoimmune hepatitis. But sometimes the simplified criteria can miss some atypical autoimmune hepatitis patients. Recently, Professor Oskar Luss from Germany evaluated the methodology for immunoserological testing. They found that immunofluorescence test, IFT, on Hep2 cells is valid alternative to the standard ANA assessment on rodent tissue sections. And ANA ELISA and actin ELISA represent potential alternatives to IFT in diagnosis of autoimmune hepatitis. So you can see the ANA by red and see Innova has a good ROC area, and also the affecting is very useful in the diagnosis of autoimmune hepatitis. So they update the simplified criteria in the autoantibody section. If ANA SMA affecting positive, they got 1 point. And if ANA SMA affecting strong positive, the patient got 2 score. So in the treatment aspect, AL30 recommended that for children or adults who presents with autoimmune hepatitis who do not have cirrhosis or acute severe autoimmune hepatitis, they can treat with the budesonide and azacitidine or prednisolone with azacitidine as the first-line treatment. For those patients with cirrhosis, they cannot use budesonide to treatment. So this figure showed the treatment strategy in autoimmune hepatitis and autoimmune hepatitis with cirrhosis. In detail, we can initiate the budesonide with dose 20 to 40 milligram, or budesonide 9 milligram per day, and add the azacitidine 2 weeks later, and gradually decrease the prednisolone dosage to maintain dose. And we need maintain this treatment more than 22 years. And in acute severe disease, we can start steroid with a higher dose, prednisolone 60 milligram per day, and evaluate the response. If they have a good response to steroid treatment, we can continue the treatment and add immunosuppressant afterwards. If they the clinical get bad, we need to shift patients to liver transplantation center. So the treatment of goals for the autoimmune hepatitis patients is to obtain complete biochemical and histological resolution of disease in order to prevent future progression of liver disease. It's our patients with G3, S3 disease and treated with steroid, it can become G0, even S0 after 3 years treatment. So after 2 years in immunosuppressive treatment, complete biochemical remission can reach to 80 to 90%, and histological remission can reach 55 to 70%. So Askar's study showed that if the patients have a complete biochemical remission, the histology degree is quite mild. If they didn't reach the biochemical remission, the histology activity is high. So the FibroScan can detect the changes of fibrosis non-invasively. So in biochemical remission patients, the FibroScan score can decrease gradually, but in non-biochemical remission patients, this score can increase. So in our cohort, 40% of patients treated with prednisolone alone, and 30% patients treated with prednisolone and azacitidine, and 27% patients treated with prednisolone and MMF. The response, biochemical response, is around 80%. And most patients can reach complete biochemical remission within 1 year. So we also did the second biopsy after patients treated with steroid 3 years later. And there's 142 patients, and 68% of patients have a histological remission, and 30% still have some degree of inflammatory activity. So as expected, if patients have a histological remission, they have a higher 90% of patients have a regulation of fibrosis. But in histology activity group, the ratio just around 60%. So we need get the biochemical remission and histological remission. And the final aim for the autoimmune hepatitis treatment should be acute the patients. So Oscar Ruth published a new paper in Journal Hepatology to as a position paper of International Autoimmune Hepatitis Group to illustrate the strategy of management of autoimmune hepatitis who has insufficient response or intolerance to the steroid or immunosuppressant. It's quite a little bit complex, but if the first line treatment failed, we need second line drugs such as MMF. If there's still intolerance or insufficient response, we need a third line treatment, which include the FK506 or biochemical agents. So LSD also recommended some point of management of acute severe patients. Those patients can treated with prednisolone firstly. If those patients improve, we continue prednisolone and add azathioprine as steroid sparing agent. If the patients no improved, we need to consider liver transplantation. If patients with acute liver failure phenotype, we need a list for the liver transplantations. So in the near future, we need more non-invasive biomarker for the high-risk disease at diagnosis, and we need to improve the response. We need even need a second line treatment or even steroid-free regimen for the autoimmune hepatitis patients. We also need to notice the recurrent disease post transplantation and the de novo autoimmune hepatitis. So thank you for your attention. Professor Jafri?
Yes, thank you very much indeed for a wonderful talk. A couple of things, basically what I would like to hear from you regarding the overlap syndromes. That certainly, in fact, bother us quite a bit because, you know, overlap syndromes really, you know, we're nowhere. We're thinking of, you know, primary biliary cholangitis with autoimmune, or, you know, one or the other dominates. But, you know, and histology cannot be repeated that often. And in those cases where, of course, you know, you have a high ALP-FOS, a high GGT with ALT, AST, and the bili, but, you know, the diagnostic features on a liver biopsy for PBC is missing. And here we are, we always treat them with URSO as well. But, you know, that's all we do with steroids and azathioprine and URSO. But there is an element of nervousness as to the real entity that we are dealing in that way. So could I hear from you regarding how do you look after those subset of patients?
Yes, thank you for your very good question. In my clinic, we have more PBC patients, maybe double to the autoimmune hepatitis in my patient centers. Among PBC cohort, we have more than 10% of PBC patients have the features of autoimmune hepatitis. So we can call them PBC-AH variant syndromes. The international field, they want to say it's a variant syndrome from the typical PBC. So the diagnosis of PBC-AH variant syndrome is difficult. The golden criteria for those syndrome is a Paris criteria, but for me, the Paris criteria is too strict to diagnosis a typical PBC-AH variant syndrome. They need a very high AST/ALT, more than 5-fold of upper limit, and the IgG levels need more than 2 upper limit of. So in histology, they need a moderate or severe interface hepatitis. If you satisfy 2 points of this 3, you can diagnose as a variant syndrome. So we did a study retrospectively, showed that those PBC patients' response to steroid treatment have average IgG levels around the 1.5 of upper limit of normal. So we propose maybe we can decrease the levels of IgG to 1.5 to include more patients with PBC and has the autoimmune hepatitis features. And so international field also want to refine the Paris criteria, I think. So most variant syndrome patients respond to the combination treatments with UDCA and steroid, even immunosuppressant treatment. Thank you. We did more than 30 patients with PBC-AH variant syndromes. Those patients with 3-year combination treatment, 2/3 of those patients have improved inflammatory degree, even decreased the fibrosis score after treatment. Yes. So Professor Jafri? I didn't hear you. I cannot hear you. Please.
Sorry. Okay, now you would hear me. Okay. So there is a question: in autoimmune hepatitis, are there some close relations about tissue fibrosis and iron gut hepatic situation? For example, liver producing hepcidin biosynthesis and iron tissue deposition during the chronic inflammation. So that's one question. I wonder if you would like to answer it. And there is another one as well. What is the relationship between HIF-alpha, mTOR, and angiogenesis under the progression of liver fibrosis in chronic autoimmune hepatitis? In autoimmune hepatitis, are there some close relation about tissue fibrosis and iron gut hepatic situation? For example, liver producing hepcidin biosynthesis and iron tissue deposition during the chronic inflammation. So it's basically between the iron absorption and the iron gut, the hepatic situation. That's what the questionnaire, it's a question from Japan by Kenchi Furia. He would like you to answer that, please.
So I cannot catch the exact question. Can you repeat the questions?
Yes, I would do that again. In autoimmune hepatitis, are there some close relation about liver fibrosis and iron gut hepatic situation? For example, liver producing hepcidin biosynthesis and iron tissue deposition during the chronic inflammation. What is the relationship between HIF-alpha, mTOR, and angiogenesis under the progression of liver fibrosis, tissue fibrosis in chronic autoimmune hepatitis?
Okay, I got it. Okay, Professor Jafri, I got the questions. Some in autoimmune hepatitis, we didn't observe a lot of deposition of iron in histology. It's a good question. Hepcidin, the association, hepcidin and the fibrosis, it need to be maybe research in the futures. But right now, I didn't notice the relationship with the iron and the fibrosis in autoimmune hepatitis. But in PBC advanced stage, the COPE deposition is quite common in PBC cirrhosis patients. Thank you for your question.
Okay.
Yeah.
Now the next question for you is, in your cohort of patients, what percentage of patients need tacrolimus?
Tacrolimus, we usually use aspirin for the first line treatment. Second line treatment is MMF. It's maybe less than 5% of our patients receive the tacrolimus, FK5 or 6. It's a third line treatment. So in our cohort, I feel that most patients have a milder disease than Western countries. In Western countries, they have a very active inflammatory disease, and we have maybe several patients didn't respond to the MMF. We add the FK5 or 6 agent to those. They can have a good response. Otherwise, the MMF. Okay. Yeah.
Thank you. There's another question in Japan. Some center do serial CT scans to assess progression in fulminant AIH. Any comment?
Your CT scan. We don't use CT scan to monitor the fibrosis progression, but we use the FibroScan as a regular detection for the fibrosis progress or even the improvement. Yes, we did a lot of paired biopsy when we want to stop the immunosuppressant treatment.
All right. Okay. In some overlap patients, some of them do lose AMA over time. Any comment?
I think the PBC and the AIH can show up gradually, one by one. Even some patients have a disappeared AMA at the duration of a follow-up. But the percentage were quite lower. I think most PBC patients have a stable titer of AMA antibodies. Yes.
Okay, and the last question is a simple one. With high efficiency FibroScan, why do we have to do liver biopsy? The question comes from Nepal.
Okay, so when you treat patients more than 2 or 3 years, we want to stop the immune suppressant or steroid. But in some patients, even with a very good biochemical response or lower FibroScan score, they still have some degree of inflammatory activity. So
and I ask a brief question. I know we're running out of time. A very enjoyable, Professor Ma.
Thank you.
For severe autoimmune, you mentioned intravenous steroids. What dose do you give? We published last year that we go up to 100. I mean, that was the APASL data, up to about 100 milligrams of methylprednisolone. What is your experience and advice on severe or fulminant autoimmune?
Yeah, we use the moderate dose of steroid, such as around 60 milligram. I don't want to use a very high dose of steroid, since those patients can develop pneumonia or lung infection, even the fungal infection. And another strategy is add immune globulin at the same time to protect the infection. I read your paper, the chronic, acute on chronic disease in autoimmune hepatitis. So I enjoyed the paper. The average dosage of the study also around 40 milligrams. Am I right? Yeah.
Yes.
Thank you.
Thank you very much.
Thank you.
I think we've all enjoyed your talk very much indeed. And thanks ever so much. Let's hear our next speaker. And for that, may I request Professor Wynn to kindly introduce him, and then we can go along. Thank you so much.
Thank you very much, Professor Jafri, for co-chairing with me and inviting the first speaker. The second topic is the management of portal hypertension during COVID-19 pandemics. And the speaker is no other than Professor Xiaolong. Professor Xiaolong, we met many times. He is a character. I've never seen such a very active scientist, young professor. And he is a vice dean of the Lanzhou University. And he is the chair of the Chinese Society of the Study of Portal Hypertension. He's a vice chair of the APASL Portal Hypertension. He is really, really dedicated to portal hypertension. So I must say, he is the most appropriate speaker for today's the title, Portal Hypertension during the COVID-19 period. Professor Xiaolong, please. Thank you very much.
Sure. Thank you very much for the kind introduction of Professor Wing. Can you see the slides? Excuse me, can you see the slides?
Yes.
Okay, thank you. So my name is Xiaolong from the Lanzhou University Hospital, and also I'm the chair of CHES, Chinese Portal Hypertension Diagnosis and Monitoring Study Group. So today my topic is full course management of cirrhosis and portal hypertension during the COVID-19 pandemic. So actually, I have 16 recommendations for the colleagues in this field, and it's also published in a Chinese journal as a Chinese consensus. So as we know, the number of the confirmed cases and the deaths of COVID-19 is still increasing, according to the report of WHO. And in the In the very early time, we published the first paper of the CT imaging of the 2019 novel coronavirus pneumonia, because at that time we still call the 2019 NCOV, not the COVID-19 as we know. We published the first paper on January 31st. And then the RSNA released the first news to report the CT imaging characteristics of this new disease, and the picture used our papers. And then we initiate another study in China focusing on the COVID-19 patients with liver injury. This is a prospective multi-center study, and we enrolled 31 patients and report the clinical characteristics and outcome of these subpopulations. And then we initiated another study, focus on the COVID-19 patient with pre-existing cirrhosis. And this is the first report of the clinical course and the risk factors of mortality of this paper. So although we screened more than 3,000 the COVID-19 patient in China, but only 21 patients with pre-existing cirrhosis was included in this study. We report some characteristics and the baseline parameters which can be a predictor of the mortality of these populations. ASLD and ESO also initiated 2 global case registration studies, secure cirrhosis and COVID help. And in this very early registration study, the CHES, my group, also participate in this study, and we report the high mortality rate of susceptible to infection in patients with pre-existing chronic liver disease and cirrhosis in Journal of Hepatology. And the final report, we enrolled more than 700 patients, which is under review in Lanzhou now. As you know, more than around 2 to 11% of COVID-19 patients have underlying liver disease. And our preliminary results show that the main cause of death of these COVID-19 patients was respiratory failure, but the acute progression of liver disease. So recommendation 1 from the Chinese experts is patients with portal hypertension are potentially susceptible to COVID-19, which increase the risk of severe illness and death from COVID-19, and thus should be closely monitored for susceptibility to infection during the pandemic. And also the patient with stable condition should prioritize telemedicine or nearby medical care to reduce the risk of transmission. And patients presenting with acute decompensation events should undergo testing. Streamline the disease assessment process should limit the length of hospitalization and provide timely treatment while implementing the hospital infection prevention and control measures. In the March 30, the Professor Chen from a CHES group published the paper in Lanzhou Hepatology to report the prevention of susceptibility to infection in patients with decompensated cirrhosis. And he reported the precautions should send to all patients with decompensated cirrhosis via WeChat. It's a social media. And also he reported several measures taken for the inpatient with decompensated cirrhosis. You can see a lot of details in this paper. So the recommendation is to build online doctor-patient consultation platforms, set up patient health profiles managed by design personnel, and improve their access to medical care. And attention should also be paid to mental health because at that time, especially in the January, China faced the first wave. So everyone is very anxious, especially for the cirrhosis and portal hypertension patient. So we should provide mental health support for patients with portal hypertension in the pandemic using multidisciplinary physiology consulting and epidemiology publicity and education to relieve anxiety and maintain healthcare. So the ESO also published a nutrition screening and assessment in cirrhosis last year. For the cirrhosis patient, as normal, a soft and easy to digest diet is recommended, and the rough and hard foods should be avoided. It is necessary for this patient to have enough essential nutrients to promote health and maintain good immune status. We also establish a flow chart to triaging poor hypertension patient. If in the outpatient, based on the temperature measurement and epidemiological history taking, but in inpatient, for the triaging, we divided patient into 3 categories. One is confirmed COVID-19, without COVID-19, and with suspected COVID-19. We have a lot of details and different measures how to put the patient in the 3 categories. This is English version, but we publish a Chinese version in Chinese journal, but we will see if we can have an English version later. So in China, the patient health codes in our cell phones must be checked before entering the hospital. And after collecting the epidemiologic history, the conventional CT scans or high resolution CT scans of the chest are carried out within 1 week before admission. And routine blood tests and other laboratory tests are performed within 2 days before admission. And for qualified medical centers, screening for the viruses, including nucleic acid test, or the swabs, or the serums, or the serum antibodies is needed. So another recommendation is for patients with COVID-19 and poor hypertension. Active treatment should be given to control the COVID-19, and attention should be paid to assessment of the underlying liver disease, and use of hepatotoxic drugs should be avoided, and liver function monitoring during treatment should be strengthened. And patients with poor hypertension should also limit outpatient visits. In the very early time, like the February or the March, almost all of the hospital in China limited the outpatient visits. Maybe only 1 to 2 the family can be see the patient. So patients should prioritize the nearest hospital for follow-up visits and take adequate self-protection. Establishing a patient management system while online platforms is really recommended, since this helps to maintain the continuity of the diagnosis and the management. And according to our CHEST 2002 study, we found that lower lymphocyte and the platelet counts and high directly globulin levels are the high risk factors for poor prognosis. And another study from Italy showed that the severity of a lung and liver disease several scores can independently predict the 30-day mortality in this patient with COVID-19 and cirrhosis. And the 30-day mortality rate was significantly higher than that of a patient with bacterial infection and COVID-19 without cirrhosis. As we know, APASL also initiated the international case registry study, APASL, and in patients with cirrhosis, the higher childhood stage of liver disease and the more liver-related complications. And if the patient with childhood score more than 9 points can predict the high mortality of this patient. And high globulin and AST-ALT ratio can predict mortality of cirrhosis. So recommendation is, besides screening of viruses infection, monitoring of the liver and coagulation functions and inflammatory indicators should be intensified to prevent poor hypertension related complications. And regarding the ultrasound examinations, a multi-center observational study confirmed the lung ultrasound score was predictive of pneumonia severity assessed by a chest CT scan and clinical features. And a specific score, we call the right ventricular longitudinal strain, measured by ultrasound, was a very powerful predictor for high mortality. So we have one recommendation letter for the ultrasound, and control the infection should be the primary goal. And ultrasound examinations should be postponed appropriately to avoid cross-infection between the staff and patient. And for COVID-19 with decompensating poor hypertension, priority is given to dealing the life-threatening complications while controlling poor hypertension-related complications. And ultrasound are performed based on clinical needs. Regarding the imaging examinations, and we have another the prospective multi-center study, we enrolled around 100 patients with COVID-19, and we established a machine learning-based CT radiomics features and showed the feasibility and accuracy for predicting the hospital stay in patient with COVID-19, because in some high burden, the hospitals, the beds is very limited. So we should predict who should need the beds for a long time. So patient with COVID-19 and portal hypertension should be closely monitored for risk of bleeding from varices, and imaging examinations, especially CT, high resolution CT, can be used as a surrogate tool for the diagnosis. And also we can use a CT as an evaluation of a severity of collateral circulations in patient with cirrhosis. And if the patient, regarding the endoscopic examinations, because it's invasive, minimally invasive, and can be easy to transmission between the medical staffs and the patients. So endoscopic examinations only for the diagnosis purpose can be postponed or use non-invasive surrogates. And for patients with acute varices bleeding or scheduled to receive secondary prevention, endoscopy operations should be performed in a special isolation place and under close protection, and operation and disinfection procedures should be strictly obeyed. And we also highlight one study in our, we do it in 2018. It's about manual control capsule endoscopy for sizing of varices bleeding. It's a non-invasive procedures when the patient just swallow the capsule, and we can use the mechanical machine to control. And in the study, we enrolled 102 patients from 12 centers, 11 from China and 1 from the Jafri University from England, and we showed the feasibility and accuracy of the MCCE, detachable stream mechanical control capsule endoscopy, with the regular endoscopy as a reference standard. So in the specific time, the COVID-19 pandemic, some hospitals in China, they use this MCCE, magnetic control capsule, for the screening varices for the portal hypertension patient. And we also know the HVPG, hepatic venous pressure gradient, is the reference standard for the portal hypertension. Since HVPG is very important for the full course management of portal hypertension patients, so patients who will undergo HVPG measurement on clinical needs during pandemic, the operation should be performed after rolling out COVID-19 infection. And during the pandemic, endoscopic treatment as the first-line therapy for the portal hypertension require risk assessment and different management strategies. And for the patient with COVID-19 combined with portal hypertension, liver function monitoring should be standard. I have mentioned it before. And for patients at risk of GI bleeding, early enteral nutrition and drug therapy should also be given. If the patient who are scheduled to undergo selective surgery should be strictly screened for COVID-19, because in China, in some rural place, the surgery therapy is still used for the portal hypertension treatment. And if the patient with acute varices bleeding, non-surgical treatment is really recommended, like endoscopy treatment or the tips before COVID-19 infection is thrown out. But for those who failed from non-surgical treatment with suspected or the COVID-19, the MDT, multidisciplinary discussion, should to determine the risk and benefit from the surgery. And emergent surgery can be performed on the 3 levels, the highest level protective measures. And lastly, regarding the intervention therapy, including TIPS, PTVE, Bertel, or the partial splenectomy artery embolization. So our recommendation from the intervention radiologist from China, they recommend patients with suspected or confirmed COVID-19 should undergo selective intervention surgery after the cure in a designed hospitals. And for the suspected or confirmed COVID-19 with acute varices bleeding, the operation should be performed on the highest level protective measures. And emergent intervention procedures in this patient should be performed in negative pressure operating rooms. So this is my lecture to share the experience from Chinese experts about the full course management of cirrhosis and portal hypertension during the COVID-19 pandemic. So we have totally 96 experts with the background of hepatologist or the gastroenterologist or the intervention radiologist. We have 3 meeting online to decide this consensus. I'm very happy to share this experience with our colleagues in the field cirrhosis and portal hypertension. Thank you very much.
Thank you very much, Professor Xiaolong. Like always, your lectures are very, enticing, full with all the latest material, full of evidence, and the people will have many questions. One of the questions for you is that, do you routinely do prophylaxis EVL in patients with portal hypertension with big varices during the pandemic?
Yeah, so this is a question, this is a very good question regarding the first prevention of esophagus varices. So actually, I think we can still divide it into different the phase. I have to say, in late January or the early February, almost all the design hospitals stopped everything in China. And if we stop all the outpatient and inpatient, because I can take my hospital as an example, Lanzhou, the first hospital of the Lanzhou University. So Saray had the chance to visit my hospital. So in Gansu province, all the COVID-19 patients was in my hospital. So at that 2 months, we stopped everything. Okay, so in my hospital, we didn't do even the screening, even to the endoscopy diagnosis, we stop everything. But because we take every patient in our hospital, so the other hospital can do like the diagnosis or the management. But after I think after the late March or the early April, because the Chinese government controlled the pandemic in China, so we gradually back to work. And for of course, for the primary prevention, we do it now. Especially, I think from the late April, we back to the work for that kind of patient. Thank you.
Thank you very much, Professor Xiaolong. There is another question from Nadarajan. What is your experience with the remdesivir during the in case of patients with the decompensated cirrhosis of the liver? Do you have an occasion to use remdesivir in cirrhotic patients?
So I don't have data, and I think nobody have the data of this patient. You know, I have said we screened 23 designed hospital in China. We screened more than 3,000 COVID-19 patients, and we only have 21 patients with COVID-19 and cirrhosis. And all these patients based in Wuhan, because they have pre-existing cirrhosis. If outside Wuhan, outside Hubei, is always a younger patient. They don't have the cirrhosis before. And regarding the remdesivir, I think this drug is used for the clinical trial because, as you might know, the Chinese have published the remdesivir paper in the Lancet. We try to divide a patient, COVID-19 patient, into 2 categories. One is a remdesivir, one is a placebo control. But in the late March, we don't have the paper to enroll. We don't have a patient to enroll in because all the pandemic was controlled in China. So even for that study, the largest study in the remdesivir in China, we have underpower data because we didn't enroll enough data. And for the patient with pre-existing cirrhosis, I don't know if we have that case. I think even for the case report, we can see the results. Sorry about that.
Dr. Xiaolong,
after
there is one question for you. Sorry to interrupt because of the time. I thought we may miss you. Very enjoyable work and congratulations.
Thank you.
Now, are you able to do FibroScan or your Chinese version of FibroTouch as frequently, or you are not able to do the same frequency?
So you mean to compare the FibroScan and
No,
FibroTouch?
no, not comparing. Are you able to do FibroScan as easily?
Okay.
Because the nurses and technicians and doctors are worried about doing FibroScan in patients because of COVID.
Oh, in patients with COVID. So I think it's impossible to do that because in the COVID patient, we have a special isolation yard for that kind of patient. And because if we put a FibroScan in the isolation yard, we can't use it for the other people, for the non-COVID people. So we didn't do that for the COVID-19 patient.
Second is we have a very large number of patients who have cirrhosis and also COVID. And almost every second day, we have patients who are bleeding. Then a cirrhosis with COVID with variceal bleed. And some of them have been advised tips.
Okay.
I wanted to know for uncontrolled bleeding in a patient with cirrhosis and COVID positive, do you have experience from China of performing tips?
No. So for I have to. We have 21 patients with COVID-19 and pre-existing cirrhosis, and I remember only 2 have bleeding during the hospitalization, and we do the emergent endoscopy treatment for this patient, but we didn't do the tips for this patient.
Maybe we should all pool data. Maybe I'll pass on to the chair.
I pulled the data in the app colleagues. I already upload the data.
Yes.
Yeah, but for the
much,
consensus I report today, it's just a fresh consensus in China. We just published this consensus last month.
Yes.
But in Chinese,
Alice has now close to 200 cirrhosis data, and maybe about 50 plus are from ILBS. But many people, and I request everyone, with the permission of 2 chairpersons, to pull the data from Asia. The total number is about 700 now.
Oh,
but
that's good.
yes, please, Professor Win, please.
You are the king of the portal hypertension. Xiaolong is the prince of the. These are the prince and the king. And 2 more questions for Professor Xiaolong.
Please.
One is what is the effect of increased alcohol taking on the portal hypertension in cirrhosis patients? Another question is, how often do you perform tips during the COVID-19 period?
How often do we do the tips?
Yes, during the COVID-19 times.
Okay, so as I said, since the late April, so because China already controlled the pandemic, so I think because tips is already for the treatment purpose. Like my last 2 slides, I showed including tips or PTVE or the Bertol. We just do it as a regular. We don't infect by the pandemic.
And another question is, what about how the increased alcohol intake affects the liver diseases, including portal hypertension, in your countries?
You mean during
question
pandemic?
from Japan.
You mean during pandemic? Yeah. During pandemic, why? Because people just stay at home and drink more alcohol? No, we don't have the data. Sorry about that. We don't have the data. What's the difference between the pandemic or before or after? We don't have the data about that.
Well, then there's no more question. I think we come to the end of this successful webinar. And thank you very much, Professor Jafri, for co-chairing me. And I would like to hand over the floor back to the Secretariat.
Thank you very much. So now it's the end of the webinar. Thank you very much for your participation.
Thank you very much.
Thank
Hi,
you
Nachati.
for everything. Okay. Bye-bye.
Thank you,
Professor
everybody.
Loren.
Prof. Samar.
Hi,
Thank you,
Sure,
everybody.
bye.
Professor Jeffrey.
Bye, Serene.
Bye-bye, Wen.
Bye-bye.